The topic of discussion in this presentation is dry eye, and we'll be discussing physiology and pathology. Starting with physiology, first of all, tear film constituents. The tear film has three layers. First one is the lipid layer. It is the topmost layer, which is secreted by the meibomian glands. And it is about 0.1 microns in depth. Then comes the aqueous layer, which is secreted by the lacrimal glands and which makes about 7 microliters of the whole tear film. And then comes the mucous layer, which is secreted principally by conjunctival goblet cells. The constituents are complex, with as many as 100 distinct proteins identified. Spread of the tear film is mechanically distributed over the ocular surface through a neuronally controlled blinking mechanism. Three factors are required for effective resurfacing of the tear film. Normal blink reflex, number 1. Contact between the external ocular surface and the eyelids, and normal corneal epithelium. So, first of all, we'll be discussing the topmost layer, which is the lipid layer, which is secreted by the meibomian glands. The composition is of polar phase containing phospholipids adjacent to the aqueous mucin phase, and a non-polar phase containing waxes, cholesterol esters, and triglycerides. The polar lipids are bound to lipocalins within the aqueous layers. These are small secreted proteins that have the ability to bind hydrophobic molecules and may also contribute to tear viscosity. Lid movement during blinking is important in releasing lipids from glands. The thickness of the layer can be increased by forced blinking and conversely reduced by infrequent blinking. Functions include, number 1, to prevent evaporation of the aqueous layer and maintain tear film thickness. Number 2, to act as a surfactant, allowing spread of the tear film. Deficiency results in evaporative dry eye. The second layer is the aqueous layer, which is secreted by the lacrimal glands. The main lacrimal glands produce about 95% of the aqueous component of the tears, and the accessory lacrimal glands of Krauss and Wolfring produce the remainder. Secretion of tears has basic, resting, and much greater reflex components. The latter occurs in response to corneal and conjunctival sensory stimulation, tear breakup, and ocular inflammation, and is mediated by the fifth cranial nerve. It is reduced by topical anesthesia and falls during sleep. Secretion can increase 500% in response to injury. Composition includes water, electrolytes, dissolved mucins, and proteins. Also contains growth factors derived from the lacrimal glands, the production of which increases in response to injury. Pro-inflammatory interleukin cytokines that accumulate during sleep when tear production is reduced. Functions include, number 1, to provide atmospheric oxygen to the corneal epithelium. Number 2, antibacterial activity due to proteins such as IgA, lysozyme, and lactoferrin. Number 3, to wash away debris and noxious stimuli and facilitate transport of leukocytes after injury, and to optically enhance the corneal surface by abolishing minute irregularities. And the last layer, the third layer, is the mucous layer. The composition is mucins are high molecular weight glycoproteins that may be transmembrane or secretory in types. Secretory mucins are further classified as gel-forming or soluble. They are produced mainly by conjunctival goblet cells, but also by the lacrimal glands. The superficial epithelial cells of cornea and conjunctiva produce transmembrane mucins that form their glycocalyx, which is extracellular coating. Staining of diseased epithelium with rose bengal indicates that the transmembrane and gel mucus layer are absent and the cell surface is exposed. Damage to the epithelial cells will prevent normal tear film adherence. Functions include number 1, to permit wetting by converting the corneal epithelium from a hydrophobic to a hydrophilic surface. Number 2, lubrication. Deficiency of the mucus layer may be a feature of both aqueous deficiency and evaporative stages. Goblet cell loss occurs with cicatrizing conjunctivitis, vitamin A deficiency, chemical burns, and toxicity from medications. Now, regulation of tear film components is either hormonal or neural. The hormonal component is based by androgens, which are the prime hormones responsible for regulations of lipid productions. Estrogens and progesterone receptors in the conjunctiva and the lacrimal glands are essential for the normal functions of these tissues. Neural via fibers adjacent to lacrimal glands and goblet cells that stimulate aqueous and mucus secretions. Now, we are going to discuss the mechanism of disease in cases of dry eye. The 4 core interrelated mechanisms thought to be responsible for manifestation of dry eyes are tear instability, tear hyperosmolarity, inflammation, and ocular surface damage. Inflammation in the conjunctiva and accessory glands as well as the ocular surface is present in 80% of patients with keratoconjunctivitis sicca and may be both a cause and consequence of dry eye, amplifying and perpetuating disease. The presence of inflammation is the rationale for specific anti-inflammatory measures such as steroid therapy. There is a strong association between dry eye syndrome and reduced levels of systemic androsterone sulfate and epiandrosterone sulfate. The classification of dry eye usually applied is that of 2007 International Dry Eye Workshop, DEWS, with a basic division into aqueous deficient and evaporative types. Most individuals have considerable overlap between mechanisms, and it is important to be aware during patient assessment of the likely presence of multiple contributory factors. First of all, we'll discuss the aqueous deficient part, which is either Sjogren syndrome, dry eye, primary or secondary, and number 2, non-Sjogren syndrome, dry eye. Now, lacrimal deficiency, primary or secondary. The primary, for example, age-related dry eye, congenital alachromia, familial dysautonomia, or secondary, for example, inflammatory and neoplastic lacrimal gland infiltration, acquired immunodeficiency syndrome, graft versus host disease, lacrimal gland or nerve ablation. Then there is lacrimal gland duct obstruction, for example, in cases of trachoma, cicatricial pemphigoid, chemical injury, Stevens-Johnson syndrome, reflex hyposecretive sensory, for example, contact lens wear, diabetes, refractive surgery, neurotrophic keratitis, or motor block, for example, seventh cranial nerve damage and systemic drugs. Can is the evaporative component, which is either intrinsic or extrinsic. Intrinsic may be due to meibomian gland deficiency, for example, posterior blepharitis, or in cases of rosacea, disorders of lid aperture, for example, excessive scleral show, lid retraction, proptosis, facial nerve palsy, low blink rate, for example, Parkinson's disease, prolonged computer monitor use, reading, watching television, drug actions, for example, antihistamines, beta blockers, antispasmodics, and diuretics. Extrinsic factors are vitamin A deficiency, topical drugs including the effects of preservatives, contact lens wear, and ocular surface disease such as allergic conjunctivitis. Now, whether a patient has primary aqueous deficiency or evaporative dry eye, the end result is ocular surface inflammation and discomfort. There is also effect of environmental factor as well as basic classification. The dry eye workshop draws attention to the effect of environment on the type of dry eye with which a patient presents. These can be both internal, such as age, hormonal status, and behavioral patterns, and external, such as exacerbation of evaporative factor in an atmosphere with low relative humidity. So that's it with the physiology and introduction of pathology of dry eye. We'll discuss this in detail in subsequent lectures. If you like this lecture, please press on the like button and subscribe to the channel. Thank you all.